Good morning. Welcome, Dr. Maureen. How are you today?
Good morning. I'm doing well. How are you? How are
I'm
you?
doing well. I'm so excited for our conversation. You are doing such great work in the world, and so excited to bring you to the wellness world here on the
Yes,
platform. So,
yes, yes.
why don't we start off by you telling us a little bit about who you are?
Absolutely. Thank you so much, Wendy, for bringing me on here. Super excited to share with your audience everything that I do. So, my name is Morine Cebert. I am a nurse researcher of infertility. The term that's out there in the medical field is reproductive endocrinology, but I mainly study disparities and equities. And I'm a PhD trained nurse researcher. Got my postdoc in this area as well too. And it's just a passion of mine to help with decision making processes surrounding infertility and getting treatment, or whether you should egg freeze and anything within the realm of assisted reproductive technology.
I love that. So, Dr. Siebert, what made you get into this field? What drew you? This is very unique and different. People don't come out of nursing school saying, I want to get into, well, you say labor and delivery. That's what they usually
Mhm.
say, right? So how were you drawn to this work?
Yes, this is a really great story that I love telling. Out of nursing school, I went to Boston College School of Nursing. I was just trying to make it. Like, I wasn't even thinking of, specialty, that
We
just trying to make
understand
it
that.
to the NCLEX. Yes. And so I was blessed enough to actually become an ER nurse straight out of nursing
Mhm.
school. And so I did, a new grad nurse residency, and about a year and a half into the residency, I wake up one day and I just have bad right sided pain. And from my own assessments, I'm like, okay, great. I have an appendicitis. I was supposed to actually work that day. I called in. I'm like, hey, I'm calling out sick, but I'm calling in because I need a bed. And sure enough, immediately the physician, I remember when he said it, he was just like, no, this doesn't look like an appy. I feel like there's something with your ovaries in that area. And so, sure enough, after an ultrasound, CAT scan, and MRI, we came to the conclusion that there was this grapefruit sized tumor on my right ovary that was causing the pain. And they couldn't completely figure out if I was torsed or not, or if the ovary twisted on itself. And so, sure enough, within 24 hours, I was in surgery and I came out. And I remember the GYN surgeon looked at me. She goes, "Great, everything is awesome. We were able to take out the tumor. It looks benign, but we'll send to pathology." And it ended up being benign, thankfully. And then she goes, "Your ovary was torn, so it was twisted on itself, and thankfully we were able to save it. It had good blood flow." And so when she said that, I was just like, "Oh, there was an opportunity for me to lose my ovary." Like, I had no idea. Like, that wasn't really discussed in like the pre-op consultation. And then from there, I don't know, it settled with me. And because of the size of it, I actually had to take 6 weeks off of work. And one day, maybe in like the third or fourth week, I kind of just like said, whoa, what if I lost my ovary? Could I still conceive? And then from there, it was really a God moment for me. I just found all of these stories that were written in like the New York Times and all that stuff about fertility. And what I noticed in the peer reviewed literature, when I go into like PubMed and CINAHL, there was nothing about Black women's experiences with
Mhm.
fertility, despite a few New York Times articles saying that Black women had the highest rates of infertility. And so from then on, I was just like, okay, I found my passion. So I literally pivot from an ER nurse, and I got a really great scholarship to Winston-Salem State University through the Bridges to the Doctorate program. That's where I became a family nurse practitioner and was able to garner skills in research. And I was able to apply it ultimately at Duke University, where I got my PhD, studying infertility, specifically in Black women and factors that affect their decision making.
Mm, wow, I love that. And when you started talking about PubMed and CINAHL and all those platforms that we look for, our research as healthcare providers, I was thinking maybe those stories aren't on there because no one's really doing them. But are there other stories? Like, have women, written blogs? Are you finding anything like that, or any like self-published articles where they're telling their own story?
Yes, I was finding those, and eventually, when I did start at Winston-Salem State in 2015, serendipitously, there was a researcher, Dr. Rosario Ceballo. She's out of the University of Michigan. She is, I believe, a psychologist by training, and she ended up doing some really great work just examining low-income Black women and low-income groups experiencing infertility. So I had that one article that I was basing like
Mm.
everything on. So I cite her like all the time. And I fangirled when I finally met her a couple of years ago. I was like, yes, thank you. But there were a few blogs at that time. The first people that actually supported my work and I reached out to was Dr. Reverend Stacy Edwards Dunn. She's out of Chicago and she has a really great group that's still running today called Fertility for Colored Girls. And I ended up being in
Mm.
Chicago for a wedding during my master's program. And she was just so gracious and supported me. She says, yes, this work is needed. And to this day, she's definitely a champion. So she actually wrote a book on the experiences of Black women, specifically Christian Black women who experience
Mhm.
infertility and all the different outcomes that they experience. Some, ended up with a child they were able to conceive, and some adopted, or some chose to be childless as well too. And so she gives really great perspectives as well.
Yeah. What are some of the contributing factors, for Black women having the highest rates or incidence of infertility?
Yeah, so I tend to put them in two different buckets. So there's like the physiologic biology. So we'll talk about fibroids, right? African
Mhm.
American women experience the highest rates of fibroids, and fibroids themselves aren't going to cause you to be infertile. It's all about the location of them. So just in regular terms, if the fibroid is just in a layer of the uterus, that won't allow it to expand with a pregnancy. So that's where you'll find somebody who's able to get pregnant, but they can't stay pregnant, and so they have challenges, especially at different growth spurts of the baby growing, and they're not able to kind of continue with the pregnancy. Or the fibroid itself might be blocking where conception can occur, or blocking the embryo from actually like being able to attach in different areas, if that makes sense. Also,
Mhm.
endometriosis, having that amount of pain, and sometimes the endometriosis like tissue can be also a blockage to the fallopian tubes. So then now, the sperm and the egg are actually never able to meet. And so that's another issue. And what's so interesting is that endometriosis doesn't really happen highest doesn't have a highest incidence rate in Black women. It actually is higher in other groups. But we actually have higher severity of symptoms. So that's very interesting.
Mm.
Yeah.
Mm.
Um, and then you have polycystic ovarian syndrome, commonly referred to as PCOS. That is affecting the ovulation. Having PCOS doesn't necessarily make you infertile, but you'll have challenges with trying to time conception just because you don't really know when you're ovulating. Because some women with PCOS, they might have a menstrual cycle, like a complete menstrual cycle of the ovulation and the bleeding, maybe 3 times a year, 3 or 4 times a year. So, as you might assume, that's really difficult to kind of track as well too. So you have a few of those biological challenges, and then there's some social and emotional challenges as well too. One, first, a lack of knowledge. I don't know how many people I've spoken to. They're like, "Hey, me and my partner are trying to have kids," and I'm just like, "Okay, so when are you, having I really get in there. I'm getting like, intimate into their details, and I'm like, "So when are you having intercourse?" They're like, "Oh, when we feel like it, sometimes on the weekends," and I'm like, no, you need to time ovulation and track that. There's only a small window of time you can actually conceive. And so some people aren't necessarily infertile. They're probably just having intercourse at the wrong time of the month. And then the social emotional of shame. and stigma, a lot of people are not seeking the help that they need because they're so ashamed of their body not working in the ways that they thought it should work. And so they're actually prolonging the time that they actually seek treatment. And that is really like my passion of like, let's not wait. The guidelines say 6 months of trying and not conceiving if you're older than 35, and then 1 year if you are younger than 35 as well too. And what most people don't realize is that IVF and IUI and all these different things that I could talk about later, their rate of actually succeeding decreases as you wait over time and as you get older.
Mm. Wow. Wow, this is great information because fibroids, yes, definitely. Endometriosis, yes. So people aren't talking about those. I think they're just starting to talk about them a little bit, not even a lot. But what should, young women, I'm thinking about young women who have these diagnoses who kind of like just poo poo them, right? But as you
Mhm.
poo poo them and you're not attending to them, it only gets worse as you get older. What should they be doing? And I think, some of our listeners for themselves or even their daughters who, they're raising, how can we be advocating for ourselves going to the GYN office? Like, what should we be saying? What questions should we be asking?
Absolutely, and it does start with our daughters. Uh, I at different points I had to pick up jobs because of grad school and all that stuff just to pay the bills. And so one of them was like school nursing. And so one thing that I realized is that in the high school age, people's menstrual cycles, they're so painful, and they kind of we often as a community, one, we have our issues with like pain management, people taking us seriously, but we also have issues of like us tolerating a bit too much. Our menstrual
Mm,
cycles should not be affecting our lives where we have to literally take off of school and work for that week. That we are menstruating. We should be really trying to explore what that is. Sometimes it can be endometriosis. I've met so many women who finally get their endometriosis diagnosis in their 30s, and they're like, I've been in pain for nearly half my life. And I didn't realize it was because of this. And at least at that point, you can have a baseline understanding of your anatomy. Is it getting better or worse? They're still trialing different treatments for endometriosis, but at least you could start freezing your eggs. I always tell people
mm,
it's never too early to freeze your eggs, but there is a time where it is too late. And people need to understand that. And so if you end up having, for example, endometriosis or fibroids, at least you've frozen your eggs. So as you kind of figure out different treatments and all that stuff, you have helped get insurance for your fertility as well. And then also thinking about age and your goals. And this is where my company kind of was birthed out of, really defining your goals for fertility. There are some people who do not want to have children, and they've known that and all, and they are very clear about that. That's fine. But there's also people who they don't know. They're not sure the different circumstances that they would or would not. And so my goal is to really help people define that. And then from there, we can work backwards. Okay. You want to be the one that actually holds your child in your uterus, what we call the gestational carrier, right? So then
mm.
that means we need to make sure your uterus is okay. That means we need to, freeze your eggs. We need to ensure that you have a complete, you have given yourself the best chance to achieve your goals as well too.
I love that. And when do you think people should start talking about fertility? Because I think just in society, we go to school, and it's like, when are you getting married? Then it's when are you having babies? When are you get in the house? All these things. And I feel like what you're doing, and it's making me think that women need to feel more empowered to kind of be in control of their fertility. It's not like an afterthought, but whether you're in a relationship, not whether you're married, well, whatever it is, because you don't have to be married to, conceive, right, or be a mom.
Mhm.
When should we start thinking about the health of our like ovaries and fertility, and like when should we seek you out?
Yeah, at any time. honestly, a high schooler could seek me out, and that could be a
Mhm.
moment of educating them, because right now sex ed, especially in the US, is very anti-pregnancy. So it's more so, don't get pregnant. Do not get
Mhm.
pregnant. But it should really, the conversation should just be like, plan out when you want to have a healthy pregnancy. And I think from there you'll make decisions of whether you want to be on birth control or whether you want to be abstinent. And how often do you get tested for STIs? Because pelvic
Mhm. Yeah.
inflammatory disease, right? That leads to infertility. But you get to PID when you have untreated gonorrhea and chlamydia as well too. So
Mhm.
really having these conversations as early as possible. And for my friends, I've had a couple clients already. They're in their 20s. They're casually dating still. They're not in a serious relationship, and they're defining these goals for themselves. And they are absolutely setting themselves up for success, having these conversations now. And then even socially, you know, they've frozen their eggs, they've made their decisions. And sometimes freezing your eggs is not the best decision, right? But you can figure out, hey, I'm about to go into the military or start this 10-year PhD process and stuff.
Mhm.
So you really have to really think about what your life goals are too. But if you're really content on just doing maybe like a 4-year degree and your career doesn't require anything else, so you're open and you're flexible, then maybe it's not something that you should think about right now. But I do give guidelines and parameters. You don't want to wait until like your 30s or your 40s to kind of think about revisiting the egg freezing conversation. Maybe reassessing your life in your late 20s as well would be something that I would recommend. And maybe you can pursue egg freezing then, if you know conceiving a child is important to you. And once you take control of that, you actually don't have to fall into this almost sort of like rat race that a lot of my friends and my peers and even myself kind of felt for a while, of like, oh no, we got to find the right partner. I got to get a partner. And then sometimes you don't make the best decisions on partners because you're trying to beat that biological clock. And having these conversations on the front end actually helps with so many different things, not even the biological piece, but the social and emotional piece as well.
Yeah, egg preservation's not really talked about a lot. Is it something that's covered by insurance?
So typically it is covered by insurance if your employer has opted to provide that uh,
Mm.
benefit. So that's also something that I talk to people about, advocating to HR when, by the time that you're doing your insurance selections and all that stuff, they have already done their negotiations a few months prior. So that's something where you can get, so like really big tech companies like Google, Microsoft, they offer that benefit. Amazon, I believe, offers that
Mm.
benefit. But right now there's no state mandate for fertility preservation, only if you can have like a medical clearance. So, if you get diagnosed with cancer, for example, and
Mhm.
you need chemotherapy, whether it's radiation or like pills or IV therapy, it's extremely toxic to our reproductive system. And people are often rendered completely infertile after those treatments. And then in our community, sickle cell disease might affect us. And a lot of these treatments, like bone marrow transplants as well, have been known to render people infertile as well too. So it's something you can talk to your insurance companies, lobby for, advocate for ahead of time. However, when I have spoken with women who experience infertility and went through treatments, there was a couple of them that said, "I wish I would have counted the cost beforehand." I get they one woman said specifically, "I get car insurance on my car, and I don't get into accidents, and I've never really had to use it, but." It's nice to have when I actually, get an offender bender, whenever that might happen. So there is the cost of the actual treatment in the process. So there's medication and somebody going in to extract the eggs, but there's this long-term storage fee, which can vary, which can be, depending on the location, if they're if you're like in New York City, you're probably going to get a cheaper price than say if you're like in Midwestern Kentucky
Mhm.
as well. So the storage fees is something that you pay typically every year, and maybe you could talk about every month, a monthly plan too. So that can range between like $500 and $1,000 a year or so. So it's not, super cheap, especially if you're in school, but it's something you can talk to your parents or your guardians about. The people who are going to be pressuring you to say, hey, where are my grandbabies? Hey, if you want these grandbabies, you can contribute to this fund as well too. So,
I love that. I love that. Yeah, it's so important to be thinking about it ahead of time. Now, you mentioned something that I know my audience is probably like, wait a minute, go back. So
mhm,
30s, late 30s, 40s. If we're
mhm.
there and we don't have children, but we want children, what can we do? Should we be doing? What kind of
Yes, yes,
conversations should we be having?
absolutely. If you're in your 30s and 40s and you know for a fact that you want children, you want to be the one to carry the children, go to a reproductive endocrinologist yesterday. Like go as soon as possible. One, so you could just do baseline testing. To figure out the quality of your egg count, or your egg count, and then the quality of the eggs as well too. So there's a test called anti-Müllerian hormone. It is given off by a lot of the follicles in the eggs, and so that's how you're able to kind of understand the quality of your eggs. And then there's other hormones like your estrogen or follicle stimulating hormone, typically on the third day of your menstrual cycle. So the third day is the third day of bleeding. Um, and so the first day is your first day of bleeding, and then you kind of count from there. So fertility is very much so centered around your menstrual cycle. And so that is one thing to start tracking too. Is it regular? Is it starting to get longer? So are you in like perimenopause, right? And so you really want to start assessing yourself, getting more in tune with your body, knowing the facts. And I don't know how many people that I've spoken to where they're in that age group and they're just like, well, I'm afraid to find out. It's almost like not wanting to know like what state that you're in. But I really try to empower people of like knowing these numbers actually allows you to plan better and actually prevents disappointment, because at least you can understand where you're at and what procedures you need to do now. And there are some providers, if you reach a certain age threshold, they will not recommend freezing your eggs. And so you might need the time then to find a second and a third opinion and different providers that will help treat you. And then there comes the conversation of single motherhood by choice. That's something where, it's either accepted or not. And so you really have to think about at what level do you want partner involvement, if at all, in your pregnancy experience? And there's some really great people who are now coming out and advocating about their single mother by choice experience, and really highlighting, the highs and the lows, but the benefits, for the most part, of the experience.
When can someone start fertility treatments? Like, you hear it, you see it on TV, they're doing the
Mhm,
injections. When
mhm.
can you start that process if, you need it to? Is 40 too late? Is 50 too late? Is, like, when can you start that process?
Well, a lot of it all depends. Depends on what is causing your fertility challenges. There's a lot of people who don't even need IVF or IUI, so all those injections and stuff. Sometimes,
I'm sorry, can you tell us the difference between the 2?
yeah. So intrauterine insemination, IUI, is essentially a process. You'll find that often if the female, if we're talking about a heterosexual couple, right? Cisgender heterosexual couple, the female partner tends to not necessarily have any challenges at that time, or she might need some support with ovulation help. So she might take some medication to help really kind of jumpstart her ovulation and really support that. But likely, not likely, but you'll often see it done. And sometimes if a male partner has male factor infertility of a certain level. And so what they do is they take, a sperm sample, kind of like wash it down and get the strongest sperm count. And then they essentially time your menstrual cycle. And that window when you're supposed to ovulate, they inject with like essential this special type of syringe. It's not like a turkey baster of sorts, but with a special type of syringe, they
Yeah.
inject the sperm into the uterus, hoping to essentially emulate typical conception, but just
Mm.
in a doctor's office. And so leading up to that IUI insemination, depending on the person, if it's something where that female partner had to take ovulation medication, typically, every couple days she's going in to have an ultrasound just to really make sure those follicles are growing and that they're in the ideal shape to actually conceive. In vitro fertilization. So, if we talk about in vivo versus in vivo is in a human body, so that would be IUI. So we have in
Mm.
vitro, which is outside of the body. And so
Mm.
essentially, we have the female partner taking these medications, still doing the same every couple of days, having the ultrasounds. Are these follicles growing? And there's a point where they want to make sure that the person doesn't mistakenly ovulate and now the egg has like gone through the fallopian tube. So they time out everything where right before you're about to ovulate, they go in with like a needle and an ultrasound to actually extract the eggs. And so eggs are within follicles. Fun fact, you can't see an egg with like the naked eye on an ultrasound. You can just see the sac that the egg is in. And so basically they're
Mm.
pulling these follicles and then they go into the lab. And so then that's where an embryologist comes in, where an embryologist will now look at the follicles, make sure that there are eggs in there, look at the quality of them. And then, depending again on the male factor part, sometimes the sperm is directly injected into the egg, or they just put, the eggs in a petri dish and then put some sperm in there and then just really watch insemination happen and watch for the sperm to create an embryo. And then the embryo is tracked over several days. And so every day, these really highly trained embryologists go in and assess meiosis and mitosis, all those things we learned in biology, and making sure
Mhm.
that the cells are growing accurately. So sometimes you'll find that people can make like 10 embryos, right? But maybe only 2 or 3 of them are like genetically okay, and or at least growing okay. And then pre-genetic testing can be done where they actually go in and look at the DNA. And that's where sometimes you can see if someone has, Down syndrome or sickle cell or, a different panel of genetic challenges. And then from that point on, based on the embryologist grading, they have a very intricate grading system of numbers and letters and all that stuff. They will choose which embryo is actually best to implant. And so while that embryo is growing, the female partner is taking medication to help now prepare her uterus. Because the first part was to actually get the eggs in preparation. And so the second part, it's mainly the focus is getting the uterus and the lining thick enough to actually be a healthy environment for that embryo to be placed in. And so then they time out the placing of the embryo, and usually 7 to 14 days later, depending on timing and all that stuff, that's when they'll do like a blood test to test for pregnancy.
Wow, time.
Yeah.
That's all I hear is time.
Yeah, it's time. So yeah, it takes it, and one thing that one, I hope that this actually educates people and they're actually more aware of the process and stuff and how grueling
Mhm.
it is. But there's a lot of success that happens with it. But also I hope
Yeah.
I educate somebody who says things like, well, why don't you just get IVF, as if it's like a quick fix, right? And as if
Right,
this
right.
is like something you just, go down the street and, walk your dog and then you'll be fine. Like
Yeah,
it's
yeah.
hard. There's a lot of hormones, it's anesthesia, it's a lot
Mhm.
of watching and waiting and all that too. And so, yeah, my goal is to just educate people on the different processes that they could potentially be offered. Yeah.
I love that. It'll be amazing to have you, like, in our back pocket. If you have questions, you can
Yes.
reach out and have a session with you. And I do wanna touch on, because you mentioned it twice, males and low sperm count, because many times as women, it's always our fault, right? It's something
Hmm.
I did, something I didn't do. Can we talk about that, like causes? When should he be getting checked, or what he should be talking to his doctor about, or what should the girlfriend wife be talking to their husbands or boyfriends doctors about in terms of planning a birth
Same
or
thing as
pregnancy
soon as
rather?
possible. Yeah, same thing as soon
Mhm.
as possible. I've heard some interesting stories in my times either coaching people or doing my research. If you had a childhood illness, there's some, men
Mm.
who had, leukemia and all that stuff, those childhood illnesses now that are now curable. They don't
Mhm.
realize that the chemo at that time could have affected their testes and like that whole development of puberty as well too. Also any injuries to the reproductive area. So if you're playing football or hockey or very intense basketball and stuff like that, and you were injured in like your scrotum and all this other stuff, and or had different surgeries because your testicles didn't drop, because that happens often, right? In children. And so, really, just thinking about your own medical history. So, if there's any, even just like one, like, oh, you know what? I wonder if that could have affected anything, please go. And then also to the type of jobs that you work as well too. If
Mm.
you often, the males will be in these situations where they could work in like coal mines or different toxic areas as well too, that can affect fertility. But yeah, most people don't realize 20% of infertility in heterosexual couples is often female factor. 20% is often male factor, sometimes higher, but
Mm.
there's 40% that it's both. For whatever reason, you just paired with that person that also has a fertility issue. And often, reproductive endocrinologists, they work really closely, if not also trained in urology as well, and trying to help figure out. Um, ways that they can improve the sperm count, or sometimes there are different procedures where they just have to extract the sperm, or thinking about vasectomies, right? Sometimes people think
Mhm.
they're done having children, and for whatever reason, right, they get a vasectomy, but then later on they might meet another partner or feel like they want to have more children. And so, even having that conversation before a procedure like that, and you can just same way you could freeze eggs, you can freeze your sperm, and it's actually much cheaper for
Mm.
freezing your sperm because that process doesn't require, the anesthesia and all that stuff. And so, yeah, that conversation should be had. And, I've often met people where they would say like, yeah, throughout my life I've had a lot of sexual partners and stuff, and I just thought it was just luck that I didn't get them pregnant. And I'm
Mm.
like, oh no, no, that probably was a sign, that you had some challenges there. And that's a huge thing, especially within the African American community.
Mhm.
A lot of stigma as well too. Recently Kerry Washington, right, talked about finding out that her father that raised her was not her biological
Oh, yeah.
father
Mhm.
because of his own fertility challenges and them needing a donor sperm. And so, just think about all these different stories and how it happens. So, a lot of my work in the beginning is like, hey, you're not alone. This happens. And I'm really thankful for a lot of these well known influencers and celebrities coming out and discussing it. But my hope is to actually bring like medically accurate information as people are really starting to share their stories.
Yeah, absolutely. The work you're doing is amazing, and I want you to tell people about your business and how they can get in contact with you.
Yes, thank you so much. So my business is called Fertility Goals. It's a company to help people plan and define their path to parenthood. And I started off really with a low cost option. Sometimes you don't have insurance, or you have to wait a certain time to get an eval. And not in every state is different. Some will cover an initial evaluation, and that's honestly where the physician and you are working to figure out your goals for fertility. So this card deck is a conversational card deck, and it basically, from my own knowledge and research, and from what I know is asked in that first appointment, I've dedicated 46 different prompts where you basically just say, "Hey, you rank how important certain." elements are to you. So a few of the prompts are to be genetically related to your child and stuff. For some people, that's okay. Some people, that's not, a deal breaker. And so to really help define your goals. And then from there, I'm offering my services as a coach to you. Okay, these are your important factors. How do we figure out this game plan? Should you have been in a doctor's office yesterday, or do you have a little bit of time? Or should you wait to maybe, elect certain insurance coverage the next year and all that stuff? Or should you have a fundraiser with your family to figure out your needs as well too? And within the new year, I'll be developing and releasing some courses to help with decision making, mainly for egg freezing. Is it right for you? Is it something that makes sense for you based on your goals and for fertility, and then also based on your life goals as well too, and how we can strategically plan that so you have less heartache and heartbreak later on in life. And then I actually hope to train a lot of professionals to support people, because I'm one person, I can't do everything. But one thing that I found specifically in the Black community and a lot of communities that I touch with is that they're going to their spiritual leaders, and they may not necessarily be educated on what their options are. The IUI and the IVF, there's a certain amount of people that need that. And sometimes it's just your thyroid. Sometimes it's having sexual intercourse at the right time of the month. So if I can educate leaders within the communities to educate their people, that would just be so amazing. So I'm offering low cost, self-paced courses for people to get that information. And then I'm also available to speak to different groups. If you're an HR professional and you offer this service and you see people are not tapping into it, I am there to help educate and motivate people to really take control, because this really affects your emotional well-being. You cannot be an effective employee if you're thinking constantly about pregnancy loss, and all that stuff. And so you can find me at yourfertilitygoals.com. People have used it already. There is a contact me section where you can inquire. I will get back to you as soon as possible within a day, likely less, just because it comes directly to me. Don't have a team yet. And so, yeah, I'm available. You can find me on LinkedIn, through my name, Morine Cebert, as well too. And then on Instagram, I have the account at Fertility Goals. So all one word together.
I love that. And something we didn't touch on that's very important, especially to this platform, is stress, how stress impacts
Mhm.
fertility.
Yes.
Sometimes we wait so long, or we just live a stressful life that it's just not working. Things are not working because your hormones are all off, right? So,
Yes.
uh,
Yes. Yeah, definitely. Stress can kill, right? We always say that. And it can cause a lot of cardiovascular issues as well, too. And, depending on where you are in life, I actually listened to the episode with Michelle, who does fertility coaching, and she mainly supports people who are already in treatment and all that stuff.
mhm,
And so yeah, the fertility process can be stressful as well, too. And but it's also, I want to put it out there, let's not discount people's infertility as just because of stress. Oh, like go on a
right.
vacation. A vacation won't cure a blocked fallopian tube. And so
Mhm.
so I really, really, really educate people of, if you feel like you've tried everything and you've met the time thresholds, whether 6 months or a year, go seek treatment, go get an opinion, and at least understand your body more. So one, you're not blaming yourself, because so many people blame themselves for things that they are not in control
Mhm.
in. And also, they don't see infertility as a disease. You wouldn't tell a diabetic, like, oh, don't take your insulin, just relax. No, like you would just tell them
Right.
to eat healthier, take their medicine, and do everything, and follow up with their physician and all this other stuff. So,
Yeah, awesome. Well, thank you so much, Dr. Seaver. Can I take you through a quick rapid fire before we get out of here?
absolutely. Yes,
All
absolutely.
right, cool. Well, this is an amazing conversation. But before we go, let me know the first thing that comes to your mind to answer the question or finish the statement.
Okay.
Wellness means
Mm. Wellness means having joy in the state of my body and how it is right now.
I know I'm stressed when.
Oh, I know I'm stressed when I can't sleep.
My go-to stress management solution is.
Prayer.
What is something you learned about yourself during the pandemic?
Hmm. That I love, love, love my family and being in the company of people who love me.
That's yes, I can relate to that.
Mhm,
And what is one thing you want women to know about fertility, infertility? If you can get one message out there
mhm.
to women, what would that be?
It is not scary, and it is something that can be very empowering if you have the right knowledge and make the right decisions.
And my last question for you, which is very important, as healthcare professionals, what can we do to help advocate and support women on this journey?
Absolutely. From primary care to, adolescent care, oncology, of course, plays a role. Asking the question of, do you have goals of parenthood? And what can I do to help facilitate that?
That is powerful. Well, I think that's a great note to end on. Thank you so much, Dr. Siebert, for coming in. We look forward to having you back.
Awesome. Thank you so much.